Hello, everybody. I hope you're all doing fine in this very difficult time. My name is Haifa Kathrin Al-Ali. I'm a senior consultant, hematologist, oncologist at the University of Halle in Germany. And I would like to discuss today with you shortly about the rationale of the use of MDM inhibitors in the treatment of patients with myelofibrosis, particularly those who are refractory or resistant to treatment with JAK inhibitors. You all are aware of the problem that about half of our patients with myelofibrosis discontinue treatment with ruxolitinib after about 3 years. And this is mainly due to loss of response, what we call JAK inhibitor failure, mainly either due to relapse or refractory disease. And we know very well that the quality of life of these patients is really very bad, and that again the survival prognosis is very, very dismal, with a median survival of around 14 months. So I think that there is a real medical unmet need to go new ways to try to investigate new therapeutic approaches in this group of patients. And as you know, one of these mechanistic possibilities is to discuss something about the murine MDM2 in malignancy. And as you know, the MDM2 is a real key negative regulator of p53, and it modulates its activity in different ways. And we know very well for some time that malignant cells have MDM2 overexpression, and this overexpression could lead to cancer cell proliferation. Thus, it makes sense to have MDM2 inhibitors to try to restore the function of p53 tumor suppressant function, and thus we could lead to the death of malignant cells, what we call apoptosis. And again, in patients with myelofibrosis, somatic gain of function mutations like the JAK2 mutation, for example, are well known to be associated with this MDM2 overexpression in the circulating CD34 positive cells, which are very often elevated in patients with MF. And we have an oral molecule, KRT-232, which is an MDM2 inhibitor. It is selective, it is potent, it is orally available, and I think this is very, very important. And it has a rapid absorption with a long half-life of around 17 hours, which again has a very big advantage for patients because this drug doesn't need to be given continuously, but for only a few days in a month cycle, which is again, I think, a very important issue for many patients. And thus, theoretically, KRT-232 could be a new way to try to target malignant stem cells and progenitor cells in patients with myelofibrosis who have failed prior treatment with a JAK inhibitor, mainly ruxolitinib. This actually has been or is being explored in a global large trial, the KRT-232-101 trial, which is, as I said, a global trial, a 2A, 2B phase, across 11 countries, where patients with myelofibrosis, both primary as well as secondary myelofibrosis after PV or ET, who failed ruxolitinib treatment, are being investigated for efficacy and safety using the new KRT-232 drug. It is very important to remember that the data of this trial, which are presented at this EHA, are the part A trial, where we are trying to find the dosing, the safety, the tolerability, and the best schedule to be given to these patients. And it is also important to remember that only patients who were refractory and relapsed to JAK inhibitor were eligible, meaning that patients who were intolerant to a JAK inhibitor treatment are not eligible for this trial. In this part A, actually, patients were randomized into different cohorts with different schedules. Very shortly, the three first cohorts are being presented at this EHA, which includes 82 patients. Cohort A was 120 milligram orally given for 7 days, 2 weeks off. Cohort B was 240 milligram, 7 days, 2 weeks off. This cohort was closed because of tolerability issues, and patients were then moved to a schedule analog to cohort 3, which is 240 milligrams, 7 days, 3 weeks off, meaning that a patient has only to take an oral drug once daily for 1 week, 3 weeks off, and then this is repeated over months. The primary endpoint of this trial was, as expected, the spleen volume reduction by at least 35% per MRI or CT scan at week 24 and week 48, and also a main secondary endpoint was the reduction in total symptom TSS by at least 50%, again at week 24 and week 48. Overall, the patients that were included were really very ill. Median age was almost 70 years. Most of these patients had primary myelofibrosis. Most of these patients were intermediate 2 and high risk per DIPS score. 3/4 of the patients actually were either anemic or had thrombocytes below 100,000. 1/3 of these patients were even transfusion dependent. They had huge spleens, very high TSS scores, and patients were really suffering. The very important issue in this trial, which is from a clinical point of view a very good thing, but for the trial results and their interpretation, a problematic issue was that in this trial, unlike all other trials for patients with myelofibrosis, is that there was no washout for ruxolitinib prior to start of KRT-232, meaning that patients were allowed to taper ruxolitinib dose and take it until day -1, and the second day start with a new drug. This resulted, and due to the very well-known effect of ruxolitinib rebound and spleen flare after discontinuation, to confounded MRI results, particularly those of week 12. So overall, when we interpret this data, we always have to differentiate between this group of patients that had no ruxolitinib when they started KRT-232, and the other half, which is really 50-50, who really continued ruxolitinib till day -1. Overall, when I tell you about the results, that at week 12, the MRI results, spleen volume, for the group who had ruxolitinib was actually 3% above baseline at week 12, compared to -21% reduction in spleen volume in the group of patients who were off ruxolitinib. And this is very, very important to appreciate when looking at the data. Nevertheless, we had across all cohorts a very nice response regarding spleen volume reduction. And again, as I said, mainly more evident in the group of patients who were off ruxolitinib, and there was a very clear dose relationship, meaning that the cohort of patients who had 240 milligrams for 1 week, 3 weeks off, this was really the best cohort in terms of efficacy. A very, very interesting aspect, in addition to the mentioned reduction in spleen volume, we also saw reduction in TSS, which is not surprising, to be honest. But a very, very interesting and intriguing observation was the very rapid and sometimes dramatic reduction in the circulating CD34 positive cell count as early as week 12, with almost 90% reduction in the cohort of patients who received 240 milligrams for 1 week, but even 60% in the cohort of 120 milligrams. And this was maintained across week 24. And I think this is a very interesting and appealing observation, which we have to follow up. We also reported on the safety issues, which is very important. Main side effects were gastrointestinal side effects, diarrhea. We had prophylactic treatments for nausea and vomiting, and that's why these were not big issues, but diarrhea was a main adverse event that was seen in many patients. At the end, tolerability was best for the cohort of 240 milligrams over 7 days in a 28-day cycle, and this cohort, this dose schedule, is now identified as the schedule for the planned phase 3 clinical trial, which will compare KRT-232, as I said, with 240 milligrams 7 days, 3 weeks off versus best available therapy in a global trial, which is expected to start in the second half of 2020. And just as a summary, I think that this trial and these data are the first clinical proof of concept for the use of MDM2 inhibitors in the treatment of patients with myelofibrosis who have failed prior ruxolitinib or JAK inhibitor therapy in general. And again, as I said, the response was dose related, also tolerability was dose dependent, and some of the results of this trial were confounded by the lack of washout of ruxolitinib. It is very exciting, and I think we're all looking forward to moving with these drugs beyond and going to phase 3 so that we might have an option for second-line treatment in this really ill cohort of patients. And with this, I would like to thank you very much. Thank you.